Okay, hi everyone. So welcome to this talk entitled Impact Factor, Why We Still Need Research in Emergency Medicine. My name is Paul Atkinson and I'm a professor in emergency medicine at Dalhousie University and also work at Horizon Health Network in St. John, New Brunswick. So I don't have too many conflicts to declare. Just want to say some of what I will say is true. Some of what I will say isn't true. I'm not really sure which parts at times. But we will explore that together over the next hour or so. I have no financial conflicts to declare. So the objectives of this lecture really are to think big, first of all. To think, what is the role of research in modern emergency medicine? We're going to discuss the challenge of finding truth out there in this era of fake news, alternative facts, etc. Then we're going to focus in perhaps looking for ways that we together can create a journey and path towards research success and why we would do that and in fact how this might impact population health and individual health. This lecture is of course also part of the Dalhousie EBM curriculum. It's talk number 3, Critical Appraisal of RCTs and Stats. And some of the objectives from that, again, are to talk about sampling. The idea that clinical trials only represent a sample of a population and in fact do not represent the truth. We're going to talk a little bit about p-values versus confidence intervals. We're also going to mention absolute risk versus relative risk, number needed to treat, number needed to harm, and as well as perhaps getting into briefly some sample size calculations, power of studies to show a difference. So perhaps that all sounds a little bit dry to you, but I can promise you this talk is as interactive as we can make it. Okay. All of that can be distilled down really into a simple question. How do we know what is true? And if we can work out what is true, so what? How does it impact our practice? What does it mean? So let's start off with the first question of what is truth? How do we know what is true? And for this, we're going to be skeptical. So you may or may not know this gentleman, Donald Rumsfeld. He said many things that I do not agree with. However, he did say on one occasion something that is very insightful. He said that there are known knowns. Those are things that we know we know. There are known unknowns, things that we know we don't know. And then there are the unknown unknowns. Those are the things we don't know we don't know. So if we think about it, our world, our sphere of thought is often limited to the first two because we're not aware of what we don't know. And that's the challenge of the researcher. And it, in a way, actually just echoes what Plato said many hundreds of years ago. I know one thing, that I know nothing. So let's go into this with some humility. Let's look at the literature and methods of examining it in a way that understands that even the tools we have to do so are limited. So as a learner in medicine, in emergency medicine, I think it's important to realize that our view of knowledge, of truth, of the literature, of our own abilities, in fact, changes with time. We all start off perhaps in the I know nothing phase. Perhaps this is in our first week or two at medical school, perhaps right through medical school, where in fact the how much I actually know line, which is blue, is low. How much I realize there is to know is also low, the green line. And how much I think I know is also low, the yellow line. But if you notice quickly, the how much I think I know shoots up very quickly. And we enter the I am an expert phase. And this is the hazard phase. I'm not going to place a time on this. Many people reach this at different phases in their career. But if you notice clearly in this example, it way exceeds what you actually know or how much you realize there is to know. But then soon after, the green line starts to increase. That is how much you realize there is to know. And suddenly the yellow line falls back down and joins the blue line, which has slowly increased through time. So don't be disheartened when you realize that there is so much to know, because in fact, this is very common to be, and it's probably very good for attitude to learning. So the truth. Perhaps we can say that it's possible that there is absolute truth out there in the universe. Even that is debatable, but let's just say that there is. One thing that research tries to do is get at that truth. And the way we do that is by studying, by completing trials, etc. And then we infer from the study as to what the absolute truth about our research question might be. So it's inference, it's not a direct relationship. No study uncovers the absolute complete truth. Of course, many people aren't overly interested in research. Many people, as I pointed out in the learning slide, know that they know everything or think that they do. And that all of us are interested in research. It's just for people who don't know the answer, and absolutely, that's true. Sometimes, however, there are some statements that are just ridiculous and don't need to be studied. Some things are self-evident, and reports do not need any further inquiry. And indeed, there are some things that are plainly true and can't be argued about. Having said all that, certainly the scholarly aspects of CanMeds are an important part of being a medical expert, alongside all the other attributes of a good doctor. So if you want to become an expert, to demonstrate expertise, you aim for the whole truth, and this really comes down to how you treat your patients. I think it's important to realize that research isn't everything. So we're not saying that evidence-based medicine is just about the literature. In fact, it's important to factor in the clinical circumstances. It's vital that we include patient values and preferences. But of course, those alone are not good enough, and we have to add research evidence. Without research evidence, perhaps we're just basing it on an agreement, an opinion between you as a physician and the patient. And that doesn't always work out well. Expert opinion has not always borne out to be a high level of evidence. And that's not just in the obvious, like cigarettes. In fact, many drugs have turned out to have little or no benefit on a population level. So we have to change. We have to change how we think about the evidence, about research. We have to challenge the status quo. I'll start with a brief story. So the blue planet, Neptune, wonder if anyone knows who actually discovered this. In fact, there's a gentleman, a French astronomer known as Urbain Le Verrier, and he employed the mathematics explained by this other gentleman, Sir Isaac Newton, to predict the existence of a planet. So he inferred that noting the path of one planet that was not quite fitting to what it should have, the orbit didn't follow exactly what it should have in terms of Newtonian physics. He predicted, in fact, that there would be another planet that was having a gravitational effect on this, and that if astronomers were to point their telescopes at a certain time, at a certain place, they would discover this planet. And in fact, they did, and they discovered the planet Neptune. However, he got a little bit cocky, and he looked the other way towards the sun, and he looked at Mercury's orbit, And in fact, he noted that that also was irregular, and again predicted that there should be another planet. In fact, he went on to call this planet Vulcan. But of course, we all know that there is no planet Vulcan. And in fact, Newtonian physics does not always hold true, especially in the presence of a large gravitational force. Whereas Einsteinian physics, or physics according to Einstein, indeed explained Mercury's path. So what's the lesson there? It's always important to use science to predict. It can help improve our observations. But we also have to use our observations to help us improve the scientific method. So nothing is set in stone. We're still learning. We're still working our way through how to try to find the truth. Okay, so we might accept that research should impact practice, but it doesn't seem to. The RAND Center for Research and Quality in Healthcare looks to see how people are practicing in North America. And in fact, the percentage of patients receiving recommended care in their 2011 nationwide audit in the US found that only 55% were. And the best was early stage cataracts. The worst was alcohol dependence treatment. Hip fractures, AFib, pneumonia, UTI, diabetes, all these common conditions did not receive best evidence treatment. So I think it's, as noted, we may know what we're meant to do, but research doesn't always translate into best practice. So why is that? Why do some physicians seem to ignore the evidence? Well, you've all probably heard someone say, well, there's an art to medicine. Basically, this means I've always done this, I'm going to continue to do this. Perhaps there are a lack of feedback loops. People don't know that they got things wrong. Perhaps they're ignorant of the evidence. They didn't know that they should be doing something. Or perhaps actually there's a lack of trust of the evidence. In other words, I don't believe it. And I think a lot of people find themselves in that last group. So let's work through some of these reasons why research doesn't seem to impact practice. We're going to talk about perceptions, dilution, perhaps talk about research being too confusing. We'll talk about the actual methods of research, and then perhaps a new way to do things. So Dr. John Ioannidis is a epidemiologist who likes to study the literature and make profound statements about the actual practice of research. He has quite a famous paper in JAMA in 2005 where he basically stated that many of the high-impact papers of our time, when they were repeated, revised, didn't hold true. So he looked at the 49 most cited articles up to that time. 45 of those claimed to have uncovered effective interventions. But whenever he looked through the literature and found when these were retested, 14 of them, or 32%, had convincingly been shown to be wrong or exaggerated. So about a third of the top research didn't hold up when retested. That includes such things as HRT, vitamin E, nitric oxide, and other treatments out there, including certain findings about PCI, carotid endarterectomies. So these are not small things. He then went on to suggest that, in fact, that most published research findings could actually be false. And he actually went on to say that there are certain criteria or certain factors in a paper that make it more likely to be false. If the studies in a field are small, if the effect sizes are very small, if you test lots and lots of different relationships, then there's the chance that you may find one that is actually statistically significant. Greater flexibility in designs, definitions, outcomes, and analytical modes. In other words, not sticking strictly to a protocol. If there were financial or other conflicts of interest, and if more teams are involved in a field. In other words, if there was a lot of competition in a particular field and a chase to publish. So he then used some mathematical simulations and actually showed that for most study designs and settings, it's more likely for a research claim to be false than true, which is quite shocking. Okay, so that might be great for analysis of the literature, but most of us just know intuitively what is right, what is wrong. You agree? So if that's true, how do we really know that what we're doing is right, and how do we know if it makes a difference? So let's talk a little bit about perspective, a little bit about illusion, and something about bias. Perspective. There's always two sides to every story, and here we have the leaders of the British Empire and the United States in around the early 1800s. In fact, they fought a war. So who won that war between Canada or Britain and the USA? Depends on your perspective. Here we have a Canadian publication, That Time We Beat the Americans. And of course the Americans, the War of 1812, and how they gained and maintained control. Well, let's explore that a little further. If you go down to Boston, perhaps visit this museum, you might come across one of these interesting illusions. So, at first take, without studying it too deeply, what does your brain tell you about the color of these lines? So line 1, line 2, line 3, and line 4. Most people will say line 1 looks orange, line 2 looks dark red or pink, line 3 is green or turquoise, and line 4 is blue. But in fact, if we look at this more closely, we will find that both lines on the left-hand side of the screen are in fact red, and both lines on the right-hand side are in fact light blue. It's the surrounding dots that change our perspective and give us a false impression of what color the lines are. So what do you think? Which table is longer and bigger? Okay, of course it is, the one on the left. I hope you didn't think those were both the same. Whereas if I were to ask you about this picture and say, are the shapes different? Is one longer? Is one thinner? You might be shocked to find out, in fact, they are both exactly the same, and it's the perspective that changes what our brain believes. These are Shepard's tables. How about this? Which way are the disks spinning? Well, just move your eyes from right to left, left to right. You can keep doing this at your own pace and see that in fact things change. And again, this is actually your brain simulating movement. There is actually no movement on the screen. Next, we're going to listen, and I want you to listen for the word that this young lady is saying.
Bar, 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 bar.
Okay, so what did you hear? What was the word? Perhaps you agree that it was far. Let's listen again.
Bar, 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 bar.
Perhaps this time you heard bar. So, let's play these beside each other, and you can look left to right with the same sound playing and see what you hear.
Bar, 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 bar.
Intriguing, isn't it, that the brain actually simulates what we experience based not just on what we hear, but what we see and other inputs. This is of course true and explains our limited view of the universe, whereas if you're using an infrared camera or visible light, there are very different pictures of the Helix Nebula. So as I mentioned, the self-illusion. We might think that we are in control of what we believe, what we see, what we hear, But in fact, our mind is a simulation created by our brain from the different inputs that it receives. Is it trustworthy? Well, not always. Okay, this is the point where I actually ask you just to take a break, to stand up, perhaps stretch your legs. However, I only want you to stand up if you believe you are a below average healthcare provider. Okay, so how many stood up? I'm guessing not very many. Whereas in fact, statistically, half of the people watching and listening should have. Perhaps that's because we're biased. So let's talk a little bit about heuristics and cognitive biases. What's a heuristic? A heuristic is a mental shortcut. It's what we use all the time. It's how we catch a ball. It's how we know how to get to the bedroom without thinking about it. It's how we know how to get to the store in the car. We've traveled the path before. We don't even think about it. The brain has a quick, informal, intuitive algorithm to get you where you need to go or to answer a question. And these are usually helpful and means that we don't have to overthink simple things. It's kind of like the rule of thumb. If it looks like a duck, if it walks like a duck, it has a beak and webbed feet, it's a duck. Of course, that's true unless it isn't a duck. If it looks like a duck, has a beak, if it walks like a duck, it has webbed feet, perhaps it might be a platypus. So sometimes heuristics can fail and can lead to cognitive biases when we don't stop to actually think about the processing, about the algorithm. And we tend to draw incorrect conclusions in certain circumstances. Gestalt plays a significant role in this. Again, if we look at figure A, we see a triangle, but yet there is no triangle there. In C, we see a ball, but there's none there. In D, we see the Loch Ness Monster, but in fact it's not there. So our brain tends to create shapes from the information that we put in. And this is kind of relevant if we think about clinical decision rules. So the to simulate 1 second of human brain activity actually takes over 80,000 of the world's top processors for 1 second. In other words, our brain is quite an incredible computing device. And yet, we tend to believe at times that a 5-point clinical decision rule or similar can replace the heuristics and the cognitive function of the brain. Is that likely? Well, it depends how we use the brain. So let's talk about anchoring bias and adjustment heuristic. What is adjustment heuristic? Well, it's used to generate an answer to a question, such as a differential diagnosis. So often when using this heuristic, we make a first pass guess, and then we add information to that until we're happy with the answer. This is pretty much like Bayesian thinking, using pretest probability, using the likelihood ratio of a test. We come up with a differential diagnosis or a likely diagnosis, and then we alter that based upon other information we gain from tests and results. However, unfortunately, sometimes that first pass guess can be anchored, it can be weighted too heavily and it won't move. Therefore, it doesn't matter what tests we apply, we end up stuck with what we thought about first, and that's known as anchoring bias. A great example of this is chest pain. In fact, we formalize that bias in the CTAS rules where we say we give somebody a presenting complaint of chest pain non-cardiac. How more biased could one be? Because to move that to cardiac, one has to completely shift in terms of what we think about it. So is this also true in research? Yes, it's known as experimenter's bias. So those of us who research, who write papers, we come up with hypotheses, and in a way, we want to prove our hypothesis. So it's hard to end up publishing or promoting something that you do not believe to be true, even if that's what you find. And the flip side of that, of course, is that when you do find something, you don't like other people poking holes in it, and so you defend your thesis. And that is the academic world that we live in. So let's talk a little bit more about heuristics, biases, and beliefs that perhaps aren't quite true. No, this is not God passing by, it's simply a cloud in a thunderstorm. But our brain is very apt at looking for patterns, and we'll see patterns that aren't actually there. It takes in random information and creates something that it expects to see. How many people here can see faces? Well, in fact, they're very clear. Your brain has created faces in all these objects that are just not there. Now, once we've decided that we believe something to be is true, it can be hard to shift that, and we are liable to confirmation bias. And then what we actually do, we look for evidence that supports what we have decided to be true. And we will avoid evidence that might counter this. Classic example might be a line drawn through a scatter plot. Once you believe this line to be true, even though there's absolutely no truth to it, it might be hard to shift that balance. So what I'm going to try to do, just to prove this to you, is I'm going to try to implant a false belief that you will believe to be true for here on, forever. If you're old enough, you may remember this song by Britney Spears, Baby One More Time. So, we're going to play a line from this. Now I want you to listen to it. Now I want you to listen for any hidden message. See what you can hear. Okay, anyone hear anything unusual? No? Okay, let's play it backwards. Now this time listen. Listen really hard. You hear anything at all there? No? Okay. All right, I want you to read the words on the screen. I'm not going to say them, I just want you to read them. And then let's listen to that clip again. Surprising. However, now I want you to try not to hear those words. Do not hear them. Wipe them from your mind. They're not true. They're not really there. Wipe them out. Let's listen again. So there you have it. I've implanted a false belief. You believe something to be there from random sounds. You can't get rid of it. It's in your brain. It's hardwired. Difficult job. And there are many of these biases. We don't have time to talk about them all, but it's really important we are aware of them, and we are aware of our biases every time we practice, every time we see a patient, every time we read a paper or argue with someone over a certain point. So biases, chance, perceptions, confounders, it's difficult at times to get to the truth. Let's move on now and talk about perhaps one of the biggest challenges to research and evidence-based medicine. A recent report from PLOS Medicine said that there are 75 trials and 11 systematic reviews published per day. Now, I don't know about you, but I would even struggle to read that if it was per month. In fact, the rate is going up, and it continues to go up with open access publication, with multiple journals, etc., etc. The idea used to be publish or perish. Now I think the truth is that you can publish and still perish, because you will just be noise in the background in the ever-increasing number of papers. So we should ask the question, do we really need to study that? Some things perhaps are too obvious. And what about the research that is published? Perhaps it's too confusing at times. Perhaps we shy away from statistics. We shy away from challenging the paper. We even just read the blog or we listen to the podcast that tells us what to believe from the research itself. An example, of course, is stats. So here, for example, is the difference in outcome in survival between two different polymers in a certain condition. Well, you can explain whatever you want here with statistics. You can show minimal differences, significant differences, and very significant differences, all by choosing a simple variation in the outcome, that is the time. And so people can tailor stats to suit whatever message they might want. What about effect size? A picture is better than all those stats, perhaps, we tell ourselves. So here we go. Here's one study of comparing control to an ACE inhibitor in hypertension. And you can see the difference here. Let's compare that to control to ASA for prevention of cardiovascular events. So look at these again. Which is the bigger effect size? ACE inhibitor or ASA? Well, those are relative decreases. What's important to do is look at the absolute. And when we do this, we can see clearly here that even though the ACE inhibitor had a smaller relative decrease or improvement on outcomes, it has a much bigger absolute impact than ASA in the other study. So the scale is important. The absolute values are important in helping us. And we must always be careful when people give us relative statistics. Perhaps one of the best ways to understand that is the number needed to treat. That's the number of people who will benefit who would not otherwise have benefited without the treatment. And it's a very simple way to get at the absolute impact of any test or intervention. So let's talk briefly about effect size, because I think it's really important. I think very often we focus on statistical significance, and I would strongly implore people to make statistical significance something that is secondary and to focus in on the effect size whenever looking at any study. So statistical significance is the least interesting thing about results, according to Dr. Dalhousie, who stated that you should just describe the results in terms of magnitude. In other words, not just does a treatment affect people, but how much does it affect them. Dr. Cohen similarly says that the primary product of research inquiry is one or more measures of effect size, not p-values. And then if we look at Annals of Emergency Medicine, the flagship journal in our specialty, a core element of Annals statistical philosophy is the emphasis on estimation over hypothesis testing. That is, using point and interval estimates, such as the mean and confidence intervals, rather than p-values. And I think this is very clear, because the actual p-value is just a test of how believable the result is. It's not something to be sought after, but in fact it's just to help us with our confidence in the result. So if something doubles, the effect size is big, that's great, but we have to make sure that there are enough numbers of subjects in the study so that we can be confident it wasn't due to chance. However, we continue to use it. We continue to look for it. We continue to report it, despite statements from the American Statistics Association, who have said that statistical significance is not equivalent to scientific, human, or economic significance. Any effect, no matter how tiny, can produce a significant p-value if the sample size or measurement precision is high enough. So let's not seek after the p-value. Now, in terms of how we critically appraise randomized controlled trials and statistical tests, there's a pretty simple approach to this that we should all be aware of. As I mentioned earlier, there is the general population that's out there. We have to sample that population. We have to do that randomly. We should then randomly assign our study population to the two different arms, a current treatment versus a new treatment, or perhaps a treatment versus placebo. And then simply measure in each group those who improve and those who do not improve and make some basic comparisons. And we have to make sure that our study population is representative of the general population, and that each arm of the study should be equal in all things as far as possible, other than the actual treatment that we're looking at. So sampling is important. P-values versus confidence intervals, risk, NNT and NH, and sample size. So the standard that we use for RCTs, of course, is the consort statement, and I think it's worth just spending a couple of minutes thinking about that. There's a few basic criteria that they ask for. They ask for you to register the source and number, a clear depiction of the elements of randomization. How did you generate the sequence? How did you allocate people? And was it concealed? In other words, would anyone know which group they were putting someone into in the study? A clear description of which outcome assessments were and were not blinded. You have to think about maybe perhaps the treating physician could be aware of which substance was being received by a patient or which test was being done. And importantly, also, if somebody was looking at the end of the study to look at outcomes, were they blinded as well as to which group the patient was in? There should be a simple consort figure showing the numbers, including things such as how many people were lost to follow-up, how many people were excluded and included, and protocol deviation. So if you randomize, for instance, someone to receive, let's say, an ultrasound versus someone not to, well, how many people actually got the ultrasound in the manner that they should have, and how many people in the control group perhaps received something part of an ultrasound protocol or received it later, as examples of a study that we performed where we were very strict in terms of making sure that protocols were followed. And then, of course, that outcomes should be reported with the size of effect and confidence intervals. So here you can refer to this kind of checklist to help you both plan a study, write up a randomized control trial, and of course to appraise one that you're reading. Again, we've gone through this. I think it's important that you clearly look through the consort diagram in any paper and just make sure that everything adds up appropriately. One of the boxes to be really careful with is the loss to follow up and the not analyzed. And to look for how they dealt with that in terms of whether they followed an intention to treat, i.e. they include outcomes in terms of where people were randomized to, or whether in fact they only analyze the numbers where follow-up was complete. Well, without getting too complex, I think it's also important to look at the type of RCT that you might have. So an RCT can be explanatory or pragmatic. So what does that mean? Well, an explanatory RCT tests the efficacy in a research setting with highly selected participants under highly controlled conditions. So what do we mean by that? We mean that there are lots of inclusion criteria, exclusion criteria. Perhaps they only look at a certain age group in certain settings, exclude people with conditions that might interfere with treatments, etc. Whereas pragmatic RCTs test the effectiveness, in other words, the real world effectiveness. So they basically just take most all comers who don't have significant contraindications and treat them with or without the new intervention. And this really can help inform decisions about practice and can tell us if treatment is going to work in the real world. So that's designing by the outcome of interest. But the other way to do it, of course, is by hypothesis, using the null hypothesis, or checking or analyzing to see if something is superior or non-inferior or equivalent. So how do you sample for these? As I mentioned already, in a typical classic RCT, you exclude a lot of people. In a pragmatic trial, you try to include the whole population in terms of the types of people. In terms of hypothesis testing, again, this is classically done by tests that look for statistical significance, and really the trend is to move away from that, especially in fields such as emergency medicine. And then, of course, there's subjective, where there's a cutoff, and that can help us look at the strength of the evidence. Let's talk a bit more about p-values to help us understand this, and confidence intervals. So which is better? You will, of course, have people tell you that you can't get rid of the p-value. Well, in fact, I would argue that you can. So if we look first of all here, using a p-value for the result of this test, this study, the p-value is less than 0.05, and by convention we would say that's statistically significant, but it doesn't tell you anything about the effect. It doesn't tell you if it's positive, negative. It doesn't tell you anything about the spread, about how varied the results are, whereas in fact a simple line here showing the spread, or the confidence intervals, tell us that the 95th percentiles are beyond 0, and therefore this is effective. So this is a significant trial or intervention, but we also can see the impact of that in terms of the spread. Here it's inconclusive or non-significant, but again we can see that it is the effect is a little positive, but just not significant. And here we again can see that there is a negative impact within a reverse effect. But if we just had a p-value, it doesn't give us any of that information about the direction or size of the effect. So again, I think in terms of 3 factors, in terms of how we interpret a trial, do we accept or reject it? Well, certainly the values, p-values, and confidence intervals all give us that information. But in terms of the degree of support, so how big is the effect? Well, p-values can lend information in terms of the confidence in the outcome, whether we should believe it. But the estimate of the impact of the effect and how sure we are about it, we really do need confidence intervals for that. A little bit about the history. Fisher, you've all heard of Fisher's exact test. He was the father of modern statistical inference, and he was the person that introduced the idea of significance levels. And Fisher saw the p-value as an informal index. He never said that it was an absolute, but basically he advocated 5% significance as reasonable. However, potentially clinically important differences could be ignored whenever the p-value is greater than 0.5. So you want to always examine the confidence interval. Statistically significant findings may not actually be from real treatment effects, because by definition 1 in 20 of the comparisons will be true just by chance. That's if you set your p-value at 0.05. And finally, we should never assume that the statistically significant findings are of clinical importance. As I mentioned earlier, if there's a large sample size, even a tiny difference will reach a p-value that's significant. Therefore, when writing up a paper, when analyzing or critiquing a paper, the term statistically significant is really not acceptable. What we really want to know is the effect size and confidence intervals. Okay, so when talking about this, you don't need to say significant. You don't need to say there was a statistically significant odd ratio of 2.8, p-value equals. All you have to say is the odds ratio was 2.8, and the confidence intervals did not cross 1. So simply by doing that, you were showing that it was both statistically significant and you're giving a clear indication of the range and the effect size. I've already talked briefly earlier about absolute risk versus relative risk, but I think it's important again just to reflect this. Let's look at the example here of relative risk. New wonder drug reduces heart attack risk by 50%. New wonder drug reduced heart attacks from 2% to 1%. Both are true, but one is more impactful in terms of its message. Again, we talked about the NNT. One thing I want to say just to remember here is that it has to be the average number of patients who need to be treated to prevent one additional bad outcome, because some people get better anyway. And a nice way to do this is to report it in terms of green faces, yellow faces, and red faces. So those are the people who had a good outcome, people who had a bad outcome, and those who improved because of the treatment. Okay, so the calculated risk of pain on antibiotics was 11% compared to 16% on placebo. So the resulting difference is 5 percentage points. Go back and look at this. For 100 children given antibiotics for otitis media. So 5% difference. So the NNT is calculated by the inverse of this risk. So 5% inverted is 20. Remembering that the ideal NNT is 1. So in the last example, you have to treat 20 kids to have 1 additional benefit. That does not mean that only 1 in 20 get better. It's 1 additional benefit. Ideally, for the perfect treatment, you only need 1, i.e., everyone improves with treatment, even when no one improves with control. So the higher the NNT, the less effective the treatment. There are lots of critical appraisal checklists out there. Familiarize yourself with them. I'm not suggesting that you fill them out every time you read a paper, but I think that it's a good way to structure your thoughts when you do read some original research. An alternative is to use the EBM checklist, where they ask a clinical question, what's the PICO, and then what are the author's conclusions. They have a nice 11-point checklist that you can work your way through, such as the study population included or focus those in emergency department, the randomization in terms of being adequate, in terms of being concealed, that they were analyzed in their groups, so intention to treat, that the study patients were recruited consecutively. I think that's important. That both groups were similar with respect to prognostic factors at baseline. That all participants, if possible, were unaware of group allocation. They were all treated equally except for the intervention. That follow-up was complete, and they give 80% as a cutoff. That all patient important outcomes were considered, and that the treatment effect was large enough and precise enough to be clinically significant, i.e. there's a good treatment effect size and the confidence intervals were narrow. Then one can summarize the key results. EBM provides a EBM commentary on this, which is basically looking whether you agree, disagree, or unsure. And then they come up with a bottom line, which is, can I apply this clinically? And what do I tell my patients? So let's look again at an RCT such as whole body CT in trauma. This was a paper in The Lancet a couple of years ago that looked at immediate total body CT scanning versus conventional imaging and selective CT scanning in patients with severe trauma. The REACT 2. So, in patients with severe trauma, does immediate total body CT compared with selective CT scanning reduce hospital mortality? There are 1,400 adult trauma patients with potentially severe injuries. The primary outcome in hospital mortality, there was no significant difference. And in the intervention group, there was 15.9% versus a control group of 15.7. And going against my own rules, I'm going to give you that that p-value was so close to 1 that it really showed that there was no difference. Selected secondary outcomes then, was a radiation exposure was increased a bit in the intervention group. And here we have 20.9 millisieverts versus 20.6. And here the p-value is very small, even though the effect size or difference is also very small. Hospital radiation exposure, 21 millisieverts versus 20.6, with another small p-value. So that was really interesting because the study went on to say that control group had significantly less radiation. But when you look at this, they're basing it just on the p-value. And this is why critical appraisal is so important. When you actually look at the interquartile ranges between the two, when you actually look at the medians, there's really little difference between the two groups. There's lots of other results that can be presented here, and we can go through time to imaging, time to diagnosis, direct medical costs, number of missed injuries, etc. But as you can also see, as you start to look for more and more secondary outcomes, it's possible you will find one that is statistically significant just by chance. So while the paper concluded that, in fact, a selective CT was the way to go, I think based on the fact that there was no difference in outcome but reduced radiation, I think it's also reasonable to conclude that whole body CT should be used in polytrauma patients because the effect size in terms of radiation exposure was minimally different, and yet there were some benefits in terms of time to diagnosis, time to imaging, and number of missed injuries. So it's all about how you interpret the statistics. Can you see a real difference here in radiation exposure that matters? I don't think so. Okay, so stats, complicated terms, can make research seem confusing. And I had a look at the top CAPE abstract from a few years ago and did a readability index on it and found that it wasn't particularly easy to read and you needed an average grade level of grade 15. I compared that with the same day's leading article in Globe and Mail, which required grade level of 7. Yet both had important messages. In fact, the Globe and Mail probably had a more important message than the CAPE abstract. So readability needs to be improved if research is to be implemented and understood. On the other hand, if you don't want to make it too simplified, I would caution against just turning the evidence into commandments that are forced upon people without explanation. And perhaps at times, such things such as choosing wisely, though I support completely what they are trying to do, can come across too much as a set of commandments to be followed. This can, in fact, as we demonstrated recently in a study, have a contrarian effect where people may actually resist being told what to do. So what about research? Should we do more? Should we do less? Is it easy to do? Well, no, it's not easy to do, and it's getting harder, which is a challenge because there's still many questions to be answered. So I think there may actually be a crisis in clinical research. The cost of industry-led clinical trial is now over $100 million. If you take part in a large trial, up to a quarter of centers will recruit no patients because the criteria are so strict. In fact, the median number of enrollment or entry criteria in a drug trial is now 49. There are about 158 different procedures. And so there are thousands of data points. And the time taken to complete the trial is going up and up and up. So it's harder to do good research. So let's get to the so what. So what if we can find out about the truth, if we can overcome our biases, if we can actually find out what the paper, what the evidence is on a topic? Does it matter? So does it make any difference? Does each new paper impact where we're going? Well, there's such a thing as peak effect. Is it possible we've reached that in emergency medicine research? Have we discovered all the things that we need to discover, and from here on in there's only small incremental benefits from all our new research? This is a bit like the speed that you need to win the 100-meter sprint. It's getting harder and harder to win every year as the times get faster and faster. Here you see where winners of the Olympics would have placed by today's standards. So over all time. So it's getting harder to make that difference. It's getting harder to have a paper that shows something new. An example of that is astronomical observation. In 1781, Messier's 110 astronomical objects, it took a long time. It took several months. Some people took their whole lifetime to see all of these objects and classify them. In the 1970s, there were marathons where participants tried to observe them all in a single night. So are we at peak EM research? I hope not. Seneca said that our universe is a sorry little affair unless it has something for every age to investigate. So I think we need to refocus, though, where we look. Because if we look at the causes of death, the causes of death, we can see that cancer and heart disease and respiratory disease are really quite large. And we continue to focus much of our research funding in these areas. We continue to focus some on trauma, but how much do we focus in on medical error? And I think those of us at the front line in the stressful environment of the emergency department are faced with the potential for medical error in every shift. And I think this is a great area where we could actually make a difference, research what can be improved, and actually save lives. So is there hope for the future, for research, for where we go in emergency medicine? So I was the skeptic up to now. From here on, I tend to be the optimist. Really, why research has to make an impact. We can't just run away. We can't just go into the woods and hide. There's still lots to do. There's still lots of areas where we can make a difference. But we need to target where we try to make that difference. So here's the health impact pyramid by Frieden. And we can see that, in fact, the point here is that the higher up in the pyramid requires more effort to do anything, to make a difference. And as you can see, socioeconomic factors are right at the bottom. So they have an increased population impact, if you look at the left-hand axis, with less effort required to make a difference. Changing the context to make people's decisions, default decisions, is another area. So what's that? That means removing things like pop from soda from school, not allowing cigarettes to be advertised, not having, I'm going to be controversial, cannabis stores right on the front of a parking lot near the supermarket or on the high street. So making it harder for people to make unhealthy decisions. Long-lasting protection interventions. This includes things like seat belts and monitoring of food safety. Then our clinical interventions. That's us. That's things like our the drugs we give, the investigations we do. And then, of course, counseling and education, where we try to communicate with people about good decision making. And often we think of that or education as the way forward, but in fact that is the most effort required to reach a societal impact. And so let's refocus perhaps where we can make a difference on the health of our population. In terms of the top 5 medical breakthroughs ever, discovering the X-ray, discovering penicillin, discovery of genetics, germ theory, and smallpox vaccination. These are all major milestones. So where do we go from here to make our difference, to reach our milestone? Well, it does mean putting on a different set of lenses, getting out of your comfort zone, challenging what you currently do, and looking for ways to do things better. We have to combine history and technology. We've got to look to the past to see how things were done, and then look to new technology to see how we can perhaps mirror some of those great milestones with new problems and new technology. Eradication of disease is still important. There are still diseases across the globe that can be eradicated, and we need to focus on how that new technology can help us. Antiviral drugs. What about advanced technology? This young lady went without a heart with an external cardiac pump for 118 days. What about genetic analysis, helping us focus treatment on the individual rather than just the population, and predicting disease before it actually happens? Gene-based cancer therapy, targeting the actual cancer for that patient, and again, not just a widespread toxic approach to cancer. Robotics, losing an arm or a spinal cord injury. Maybe traditional medicine can't help there, but robotics may provide solutions for these patients. Restoring sight to the blind with technology, prosthetics, and of course resuscitation with advanced technologies such as ECPR or ECMO provide great areas for research and potentially for saving lives in our field. So do we need a new plan, a new way to do research in emergency medicine? Incorporating technology, incorporating how we think. What about the methods, how we do it? So Tim Coates, a few years ago, asked this question: what type of primary research is best suited to emergency medicine? He acknowledged that we can't be experts in the science of everything, but perhaps we can be experts in a particular type of methodology that can be applied to many different areas. And he very much proposed this idea of the pragmatic trial, or what I like to call the randomized open control trial, as opposed to the closed or tightly controlled RCT, and we touched upon this earlier. I think this is really important just to revise again, that RCTs typically are tightly controlled, large number of entry criteria, homogeneous patient groups with really well-defined protocolized interventions, and this can be very difficult to perform in the emergency setting. On the other hand, a pragmatic trial or an randomized open control trial, we do not try to constrain the non-trial treatments. So we have one intervention for one group and a control or some other intervention in the other group. But other than that, they receive the usual care that they would. In fact, we welcome the variation in the study population. It's seen as a strength, but we hope that it is evenly distributed throughout each of the two groups. And of course, this reflects the variation that occurs in the real world, though it can provide extra challenges in terms of interpreting results. CRASH 2 was a great example, and CRASH 3 is another one of a pragmatic study. Of course, you can take a completely different perspective on this approach, and we can say that we are all different, and therefore we need different treatments. Perhaps it's better to understand individual variations to treatment rather than hoping that it will be averaged out by randomly assigning patients to large groups. As an example, there is a problem with averages, and the idea of lumping everything together can at times not be logical. So the story of, let's say, 3 duck hunters. Let's imagine that, in fact, one's a surgeon, one's an anaesthetist, and one's a statistician. And they're out hunting, and the surgeon shoots at the duck and misses by 5 inches to the left. The anaesthetist then shoots and misses 5 inches to the right. And the statistician shouts, "Great shot, guys, we got him." Because of course, on average we did, but in reality we didn't. Similarly, I decided I might cycle across Canada. Here I am at mile 0 in Victoria, BC, and I wanted to cycle the whole way to New Brunswick. So I looked at that and found, yes, I was starting at sea level and I was going to end up at sea level in New Brunswick. And so the average change in altitude was 0. Unfortunately, the reality was more challenging and I never completed the journey. So I think it's important that it is the individual components, the individual effects are important in research. And maybe with evidence-based medicine, looking at medians and means, we have forgotten about the individual and focused too much on the population. How often do we really consider the external validity of studies for our patient? In other words, the patient in front of you. Is your patient Mr. or Miss Average, where the study outcomes fit exactly? Or are they somewhere off to either side within the range? It's almost like we've come not full circle but half circle, where years ago we had individual care where you went to see your doctor, he thought about you, he thought about the options, and you received the care on an individual basis. Then we moved to evidence-based care based on population studies, where you got the treatment that was best for the population. Perhaps now we're coming back around with individualized medicine to individualized care, where we can target the best therapy for you with all your complexities and all your different influences and conditions. So if we change methods, perhaps, what about priorities? What should we focus on? Well, we know that the Australians always get their priorities right, and certainly they led the way in terms of emergency medicine research priorities, and they held a consensus meeting back in 2014 and weighed the approach to what should be researched. And they have a very simple grid, which is importance and impact on one side, and then feasibility on the other. So how important or what impact will this research make? And is it feasible? And they applied this to questions such as a hard versus soft collar, fluid resuscitation in elderly patients, oxygen in acute coronary syndromes, X-ray before and after shoulder dislocation, etc., etc. And by applying both the importance, impact, and the feasibility, they came up with a list of top research priorities for Australian emergency medicine. In the UK, they've repeated this, and they've come up with the top 30 emergency medicine research priorities just last year. So I think we need to do something similar here in Canada and North America. The other thing, of course, to these skeptical solutions for research for you out there wondering what you can do in your projects, let's think about in a low resource setting, which many of us are in, we don't have large grants. Well, perhaps this skeptical approach to research, in other words, critiquing others and doing secondary research, is a good way forward. Maybe we don't need more primary research out there. We already said that there are too many papers. Perhaps it's time to start analyzing and categorizing and doing meta-analyses and reviews of what's already out there to help us answer our questions. So of course, learning critical appraisal skills first, as this lecture is part of a course towards that. Practicing your critical appraisal skills, is important, and then build on that by formalizing that, perhaps by completing systematic review of the literature. I should mention that social media is here. We can't ignore it. Foam is out there. And so I think it's important to ask whether social media will transform research in emergency medicine or whether it will threaten it. Will it help science become more accessible to the clinician? Will responsive web-based resources provide timely, accurate, high-level reviews and summaries? Or perhaps, to be negative, will unfiltered single studies impact practice without appropriate review simply because it's a popular scientist, a popular researcher, or it's tweeted out by someone who has a large following? You can follow this and many other topics at the CGEM debate, hashtag CGEM debate on CGEM Online, where we look at many of these questions about where research and clinical practice is going. And finally, if we think about what we want to see, where we want to go, we want to get a picture like this. We want to get up high and really see what we're looking at and see the future, see the vision. Traditionally, to get that view, you had to be a bit of a Superman. You had to dedicate a lot of your time to climbing up, to reaching the top, to having people listen to you and accept your publications and influence the science or the knowledge base in your specialty. However, here are my kids a few years ago, right at the top, getting the same view as Superman of New York. How did they do it? Well, simply they took an elevator. So you have to provide stairs and elevators to the top and not expect everyone to climb the ivory tower themselves. So teamwork, structured group-based support, providing mentorship, helping each other out, not competing with each other for publication, but collaborating to achieve high-level, multi-center studies and large group reviews. I personally believe that is the way forward. We don't all have the same skill set. We don't all have expertise in every area. We must work together, collaborate, and share resources. So I think to summarize, there is still a future for research in emergency medicine, and it will continue to change and impact our practice. For you to be part of that, you need to develop a skeptical mind. Don't be too quick to believe something new, the latest paper, but don't be too slow to consider it either. You got to keep believing we can do better and not become disheartened or just fall into a rut of continuing poor practice. And I think we do have to begin to destroy the ivory tower. Research should be accessible. The language of research needs to be easily understood. We need to continue to think deeply, but to put things simply and use lots of images. We have to focus on what matters. Real needs and questions have to be addressed, not just esoteric academic questions. Ask yourself, does it matter? Is the effect meaningful? Can you test it rigorously? And in the end, don't forget that you and I, like everyone else, we're all biased. And factor that into whatever your beliefs are about medicine and life in general. To overcome this, perhaps large pragmatic trials with collaboration of emergency physicians, especially those in smaller centers outside the traditional academic centers, are required. So yes, we do need new paths to move ahead. And remember, he who asks a question is a fool for a while, but he who does not ask a question remains a fool forever. So don't ever be too scared to ask that question and go seeking the answer. I'll also quote an anonymous from Canada to say, let's stop rushing to publish, to present, and let's use our good fortune to do what we're trained for years to do, and that's to develop expertise towards answering the big questions confronting us. So perhaps we need to steer away from multiple small individual resident and learner projects and work together to really do some meaningful research. Thank you for your time. Yes, it's an uphill struggle, but it can be fun. So let's keep going. If you've got any questions, you can contact me at the email. follow me on Twitter at EcuCourse. Thank you for your time.